The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. This week I attended a conference up in Nashville. It was a Pri-Med event. I never really heard anybody talk about Pri-Med, but it's a really cool organization. They do a lot of CME and a lot of free stuff, actually. There are a lot of online courses that you can attend live or listen back to. They do podcasts. The Frankly Speaking About Family Medicine podcast that I listen to, I believe, is a Pri-Med podcast. And you can even get a little bit of CME just for listening to that. It's a pretty cool organization. They do live in-person conferences, it looks like about every month all over the country. It's not that expensive either, by the way. They are focused really on primary care, and all the speakers are very accomplished physicians, probably most of them from the New England area. I think Pri-Med is probably based up in that neighborhood, but a lot of the speakers worked at Brigham and Women's and taught at Harvard, and there were people from Chicago, Texas, California that came to speak, so it was a pretty neat way to spend a couple of days, something different than just going to work, and probably learn something. And of course, I took notes for you on the things that I learned that were either new to me or I'd forgotten. And so I'm just going to go through and pass along the tidbits that I picked up from this conference. I don't think I'm going to take the time to say who each individual speaker was. I don't know that it really matters. But they're all super smart, okay? They're all super smart doctors. I noticed at this event that usually the speaker will say, I don't have any disclosures. They'll have a slide that says no disclosures. At this conference, a lot of them had disclosures. Like most of them had things. None of them said what they were. They threw them up on a slide and said, here are my disclosures, and then moved on. But a lot of them were consultants for pharmaceutical companies, and it seemed like probably had something to do with research on some of the medications they were talking about. That's just another example of a place where money and medicine come together too much for my comfort. It always makes me a little uneasy when those two things come together. Makes me feel just a little bit skeezy. And they all did a good job of actually doing a presentation about the whole subject they were talking about and not just pitching their medicine that they were involved in. But when they got to that part, you could tell they were like, ooh, this is so exciting. Felt like talking to a drug rep, one that I was paying to listen to and not just one that brought me lunch, so I had to listen to them. I'll tell you another thing that always gets my attention when I go to something like this and hear these very accomplished speakers. They introduce these people, and you get a copy of their written bio, and it's like, Dr. So-and-so is the dean of this school and the associate medical director of this and the medical director of that and the in charge of this and in charge of that. And they see patients and they teach and they do all these things. Just these bios just go on forever. And I'm like, how do people do that? I think either these are just superhuman, very driven people who don't require a lot of sleep, or it doesn't really take a lot of time to be the director of this and the committee chair of that and blah, blah, blah. Like, I wonder if they just show up and sign their name once a month or something. But I mean, I feel like I have about 2 hours to myself every day, and that's it, ever. And, I have a full-time job, a little part-time teaching job. I volunteer in my church some, and I have a dog. That's pretty much it. A lot of these people also have families, and they start talking about, oh yeah, my kids do this, and we go kayaking and rock climbing. And I'm like, I do not understand how there's enough time in the day for some of these people to do all the stuff they do. They're also all skinny, by the way. Obviously, they have plenty of time to go to the gym and eat healthy while they're at it. Very impressive. I guess that's why I'm a lowly nurse practitioner in Decatur, Alabama, and these people are paid to come teach me about things. All right, so anyway, here we go. The first section was a knowledge test. They did a lot of interactive things. That was one thing that I noticed about this conference as well. It's very slick technologically. They had their own app, and you could follow along with the slides as the presenter was going through them in the app. You could answer poll questions, interactive questions with your device, and ask questions of the speaker as it was going on just from your phone or computer. I thought that was really slick. Okay, focus. Things that I learned. Anti-CCP antibodies. This would be anti-cyclic citrullinated peptide antibodies. Those are a better test for rheumatoid arthritis, or at least a more specific test than any of the general inflammatory markers or ANA or rheumatoid factor. For people on methotrexate who get their flu shot, you should stop the methotrexate for 2 weeks after they get their flu vaccine if possible. That's also true for rituximab, depending on when they got their last dose. Amitriptyline has an off-label indication for treating fibromyalgia. You can give a low dose in the evening for that. 10 milligrams is the recommended starting point. They do make it in a 10 milligram tablet. For COPD patients, LABA plus LAMA is actually better than having an inhaled corticosteroid in the mix if the patient's eosinophils are less than 300. They recommend adding an inhaled corticosteroid if the eosinophil count is greater than 300. There are clinical calculators that you can use for COPD to help choose therapy. The ones they mentioned are called the CAT, which is the COPD assessment test, and the MMRC, which is the Modified Medical Research Council Dyspnea Scale. Always love a good clinical calculator. The next session was on brain health and cognitive development. They talked a lot about Alzheimer's disease. The guy that was speaking, I believe, was involved in the approval process or the development of these new anti-amyloid medications. He talked about those at the end of his presentation. He talked about the older cholinesterase inhibitors that have been kind of like almost the only thing we had for dementia for a long time. I've never been a huge advocate of these just because we know they don't really do anything to slow the progression or change outcomes. He says he thinks of these as turning back the clock by about 6 to 12 months and improving people's cognitive function a little bit, even though it doesn't slow the rate of decline. He said memantine should probably only be used in moderate to severe dementia because it has a lot of undesirable side effects that could be problematic. He was talking about specific cognitive tests, and he was saying that the MMSE is really not great for picking up on mild cognitive impairment, which I agree with that just in how I've used it in practice. The MoCA is really the best one for differentiating mild cognitive impairment from just normal cognition. That's the Montreal Cognitive Assessment. And the other one that's better for picking up mild cognitive impairment is SLUMS, which is St. Louis University Mental Status Exam. He talked a lot about how hearing impairment is an important and often overlooked modifiable risk factor for dementia. And he was talking about how hearing impairment can lead to social isolation, which is another risk factor for dementia. There's another reason for people to get their hearing tests and get that fixed if that's an issue. There's a new biomarker that was just approved, I believe, in May that sounds like kind of a slam dunk for telling you whether someone with mild cognitive impairment does or does not have Alzheimer's disease. The name of this thing is the Lumapulse G p-tau 217/beta amyloid 1-42 plasma marker. It's a blood test. They don't recommend that for asymptomatic patients, so you do have to have some mild cognitive impairment symptoms in order to consider doing this. And really the only reason you would consider doing it is if you are considering using one of these new amyloid targeting medications. Those are lecanemab and donanemab. These are IV medications that are given every 2 weeks in the case of lecanemab and every 4 weeks in the case of donanemab. If you recall, these went through a kind of difficult approval process. They were controversial and they were in the news a lot, but they have been approved. He said that they can slow progression from mild cognitive impairment to dementia by up to 60%, which is pretty impressive. These are monoclonal antibody medications, of course, and the goal is to get the immune system to attack the amyloid and remove it from the brain. My impression about these things before was that they kind of make the MRI look better, but we don't know what they really do as far as outcomes of dementia. But he seemed pretty positive about it. We just saw one of their reps in our office for the first time, and she was saying that some of the local neurologists are on board with trying to start using this stuff. So maybe that's something we will be able to see shortly. The next session was on HIV testing and treatment. This was not a CME presentation because it was very prominently sponsored by a company called Gilead. And I got to tell you, there's a real fine line between the non-CME and the CME things. Like, to me, there was more commercial bias in some of the CME presentations. This guy that gave this talk didn't really say anything specific about any kind of drug or anything. I got the impression that he was not there to sell any particular drug. So I don't know really how that works. That seems like really splitting hairs between, oh, this is commercial bias and this is not. I will say this person's name. His name is Dr. Chad Zawitz. He was super duper cool. He was one of my favorite speakers. I'm going to try to see if I can get in touch with him and maybe get an interview with him for this podcast. That would be amazing. He just kind of basically reviewed HIV. Really, I guess the only thing that I wanted to emphasize was that undetectable means untransmissible, right? If a person's viral load is undetectable, which means less than 200 copies per cubic milliliter, then they can't transmit HIV. It's important to keep that in mind. He was saying that some of the assays or some labs or some different lab tests will have different cutoffs for that. So some of them go down to as low as like 40 or 25 copies of the virus per cubic ml. And so if the count is greater than that, it will flag as positive, but as long as it is below 200, that still counts as undetectable. He was talking about how to take a sexual history from a patient, and that's something that I'm interested in. I think I would be pretty comfortable working in a sexual health clinic, actually. And I think I've heard of these 5Ps before. But this is a thing that the CDC puts out, and the 5Ps are partners, practices, protection, past STIs, and pregnancy intentions. So if you need some kind of a template or guideline for taking a sexual history, that would be a good place to start. The next session was just a series of case studies on kind of difficult things to diagnose. One case talked a little bit about SIBO, which is small intestine bacterial overgrowth. That's something I don't know a whole lot about. I think I'll probably do an entire episode on that at some point. There was one with pancreatic insufficiency. One little tidbit I picked up from that was using fecal elastase to check for pancreatic insufficiency. There was a case about idiopathic intracranial hypertension, or IIH, another interesting topic I might cover at some point. In one of these cases, they mentioned a lab test called aldolase that I don't think was on my radar. It's an enzyme that breaks down sugar, and a lot of it is found in the muscle and liver tissue. So if you have muscle or liver damage going on, you can look for elevated levels of aldolase in the blood. They did a talk on can't miss infections, they called it, and really it was just kind of story time with, oh, here are these patients that had these really tricky infections and abscesses and things. I didn't really get a lot out of it. I think the bottom line was pay attention to your patients if they're sick and have something weird that doesn't just seem like a cold. The next session was on dermatology, and a new thing that stuck out to me was this medicine called ruxolitinib. This is a topical medication that you can use for vitiligo. The brand name is Opzelura. And by the way, they're so weird about saying brand names of medications. Like, can we all just quit pretending that really matters and say the brand names? Because a lot of times we don't know the generic names as well as we know the brand names, So I don't know. That seems like such a weird line in the sand to draw. But in a lot of these medical presentations and podcasts and stuff, nobody will say the brand name, or they're like, oops, I said the brand name. It's like, come on. Does it really matter? We're all shills for the pharmaceutical companies, okay? Like, can we just say the freaking brand names? But anyway, this dermatologist that was speaking was very pro ruxolitinib. She was saying that would be an appropriate thing for primary care clinicians to use to treat vitiligo. As long as the body surface area of the vitiligo does not exceed 10%, in that case, they need to be on a systemic medication anyway. The patient puts it on twice a day, and you can use it for up to 24 weeks before you reassess to see if there's a satisfactory response. The next session was about menopause, and of course they talked about the new medication Veozo, which works really well, and we are having some good experience with that in our practice as well. The thing that jumped out to me, they talked about a particular app called the CBTI Coach. That's Cognitive Behavioral Therapy for Insomnia Coach. It's a free app that was developed by the VA to help, I guess, anyone with insomnia, but they specifically mentioned it in the context of menopause. The next session, this will be the last session for day one, was about psychiatry. And he talked about apps for treating depression that are actually FDA-approved medical devices that we can write a prescription for. And then the patient uses the prescription to download the app. There are a bunch of these. The ones that he specifically mentioned are called Rejoin, REJOYN. This is a 6-week cognitive behavioral therapy program for major depressive disorder. There's one called MamaLift, MAMALIFT, which is for postpartum depression. This is an 8-week treatment plan. There's one called Endeavor that is actually a game that's designed to treat ADHD in children. Those are the 3 prescription ones that he mentioned, but there were several others that he showed. I had no idea that was a thing. So if you have a patient that is reluctant to go to therapy or doesn't have time or can't or whatever, you might potentially be able to actually write them a prescription for this app that they can use to treat their own mental issues at home without having to see somebody else. Very cool. He mentioned another one called Mood Gym, MOODGYM. That's not a prescription one. It's not approved by the FDA, but he feels like it is a good app that uses evidence-based treatment. It's designed to be cognitive behavioral therapy to help with anxiety. Cool stuff there. Day 2, the first session was all about complementary and alternative medicine, the current terminology for which is actually complementary and integrative health. I didn't really pick up a lot of specific information from this. The speaker was kind of like, yeah, this is good stuff. And she talked about acupuncture and yoga and Tai Chi and all these other things that we are starting to get more data about that turn out to be pretty good. So basically, her message was just don't be afraid of this stuff and it's okay. The next presentation was maybe my favorite. It was about irritable bowel disease, colorectal cancer screening, and acid reflux. The guy that presented it was from Detroit. The only other doctor I think I'm aware of from Detroit is Dr. Toff, the kidney doctor. And both of these guys are like really cool. It makes me think maybe I would fit in well in Detroit. I don't know if all the doctors in Detroit are like that. This guy had a really nice demeanor and was kind of self-deprecating. At one point in the talk, he brought up that Bristol stool scale, and he actually kind of made a poop joke. And he said, yeah, my mentors told me that I should take the patient seriously, but not take myself too seriously because I am a poop doctor. And it was nice to see somebody actually have a sense of humor about something like that while they're talking about it. I wrote down several pearls that I got from his talk. He talked about that colonic manometry where you leave the probe inside the colon and actually check to see how well it works. That's really the test that you use to diagnose IBS. But he said that there's no way to get reimbursed for that, and it takes like a couple of hours, and so no GI doctors actually do it. He said that GI docs are not even trained to do that except in cases of research. So that's kind of disappointing. He was talking about IBS. He said, I consider it a positive sign for IBS if someone takes out their phone to show me a picture of their poop. That definitely happens sometimes. Medications with the best evidence for treating IBS constipation predominant are Miralax and Linzess. He does not like stool softener like Colace. He said data shows that it's really not any better than placebo for patients with IBS-C. Same thing with dicyclamine. He said it's not any better than placebo to help with abdominal cramping. That was kind of surprising. I do write that all the time. There's actually better data for peppermint oil capsules. He recommended 150 to 200 milligram peppermint oil capsules that the patients can just buy over the counter, and he can take them 3 or 4 times a day to help with intestinal cramping. How about that? He's a big fan of Linzess. He said it tends to work really quickly to improve constipation, but then it also helps decrease discomfort in patients with IBS because of its mechanism where it increases cyclic GMP inside the cells of the colon, and eventually that cyclic GMP makes its way down to the nerves deeper in the wall of the colon and can actually help with the discomfort, the pain that people feel. But he said that effect of the medicine takes about 6 weeks for the patient to feel. And my experience with Linzess is that a lot of people will start it and then stop it because it kind of works too well, or they'll just use it as needed as a laxative, which is fine. But if you really want the full benefit for IBS, the patient really needs to stay on it for at least 6 weeks. He mentioned a newer medicine called Tenapanor, Tenapanor, or brand name Ibsrela, Ibsrela. He said this is really useful if the Linzess doesn't work for IBS patients. It actually blocks dietary sodium absorption, and it decreases the permeability of the intestine so that it helps water stay in the colon that way. So the goal is the same as Linzess, to get more water into the colon, which sort of works on a different level. I submitted a question asking if you could take this and Linzess at the same time since they're different mechanisms, but he didn't have any time for questions, so I don't know what the answer to that is. He said that this could help with this phenomenon called leaky gut syndrome, which kind of is not really a recognized medical condition yet. It's more of a hypothetical thing at this point where the intestine is just too permeable for whatever reason. He said there's a lot of misinformation out there about this, but if leaky gut syndrome is a thing, then a medicine like this should be helpful for that because it decreases intestinal permeability. He talked about probiotics. He said that generally those are not recommended for IBS just due to lack of data. And one thing he also pointed out was that when you test a lot of probiotic products, like they've been sitting on the shelf for a while and you take them and open them up and test them, a lot of the bacteria in there have died. A lot of them are not really shelf stable for a long time. He said that's why they put 20 billion units of these bacteria in these products so that some of them will still be alive by the time it makes it to the patient. But he's not a huge fan of the probiotics for IBS. He said the only thing that really has been shown to alter the gut biome for people with IBS diarrhea predominant is the rifaximin. That's the antibiotic that kind of stays in the gut that you really just use for that kind of thing, and also for cirrhosis patients. Amitriptyline popped up again. We talked about it earlier for fibromyalgia. He said a low dose of amitriptyline can actually be pretty helpful for cramping with IBS diarrhea predominant. He switched gears and talked about colorectal cancer screening. In our area, we're seeing a lot of the GI doctors, or I'm hearing when the patients come back from the GI doctor that they're being told, oh, don't mess with that Cologuard. You don't want to do that. I talked to the physician I worked for about that, and he said, well, yeah, they don't get paid for doing a colonoscopy if the patient's doing Cologuard. I really need to start looking at things more through that kind of lens. But this speaker said, really the best test for colorectal cancer is the one that gets done. If they're not going to have a colonoscopy for whatever reason, do a Cologuard. If they can't do a Cologuard, do a FIT test. He's definitely a fan of the Cologuard test over regular FIT testing. It does have a higher false positive rate, the Cologuard does, but the FIT testing is actually much less sensitive for picking up cancer. In a recent study, he pointed out they found a 35% false negative rate for FIT testing versus 7% for Cologuard. He said the FIT testing kind of makes up for that because you're supposed to be doing it every year. So if you do one every single year, obviously your chances of it picking up some cancer are better. But he was definitely a fan of the Cologuard over just the regular FIT testing. And of course, the colonoscopy, still the gold standard on that. He switched gears again and talked about the difference in PCABs and PPIs. I did an episode about this when I talked about the new medicine, the Voquezna, and I still didn't have a great understanding of what the difference was, I think, even after going through and doing that episode, but he explained it a lot better, and I kind of have a better understanding now of what the difference is. He was saying that the only chance that a PPI really has to get to the proton pump is while the medication is sitting in the stomach. So an hour and a half, 2 hours after you take it, it's in there. That's when it is going to be activated by stomach acid because PPIs are prodrugs that have to be activated by stomach acid. That's your window for it to work. After that, it goes on through and it's never going to be directly exposed to the proton pump again, even though it does get absorbed into your bloodstream. The PCAB, on the other hand, this is like the Voquezna, actually collects in the parietal cell and hangs around inside the parietal cell in the stomach for about 8 hours. So not only does it bind to the proton pumps while it's sitting in the stomach, like the PPI, but then it comes around the back way, comes in the back door also, and it can bind to those proton pumps before they even get poked up into the lumen of the stomach. And I think I talked about that on my episode of the podcast that I did about this. I don't know if I 100% understood the words that were coming out of my own mouth, but that makes sense. So they have a lot better access to the proton pumps for a lot longer time compared to PPIs. The PCAB is not a prodrug, so you can actually take it with food. It doesn't require acid to be activated to start working. He said it's 100 times more potent than a PPI for acid reduction, which is pretty impressive. And it also works a lot longer than a PPI. It's super helpful for treating H. pylori infections also. He was saying that you can do 20 milligrams of the Voquezna along with amoxicillin just for 14 days to get rid of H. pylori, which is a lot shorter and one antibiotic fewer than you typically think of using for that. Then he talked about the whole situation with PPIs and this kind of association that's come up with dementia or all these bad things that people are starting to hear about PPIs. And we have been kind of making some effort to get people off of PPIs and just on to H2 blockers if we can. But he was saying, look, there's really no proven link between PPIs and these things. These are still safe medicine to use. Don't be scared of them. And that's kind of my attitude as well. If you need it, you need it. It's like, do you want to maybe get dementia in 20 years or do you want to definitely get esophageal cancer because you're acid eating the inside of your esophagus all the time, He said really the only proven adverse effect of PPIs is people getting more enteric infections, which makes sense because if you're reducing the amount of acid in the stomach, then there's not as much acid available to kill the enteric organisms that it is designed to kill. So people on chronic PPI therapy are going to be more prone to getting those infections. The next presentation was about orthopedics. A lot of ortho is just way over my head. I have this kind of learned helplessness feeling about orthopedics when the experts start talking about all these different tests and maneuvers that are named after different people and all this very specific anatomy. I'm just like, ooh, I'm glad we have an orthopedic clinic. In our town, actually, the big orthopedic group has started having a walk-in clinic where people can just go to orthopedics during the day, during business hours. And we've been pretty much encouraging people to go over there when they have some kind of complicated orthopedic injury. Like, why waste your time coming to me when you could actually go see an expert on this stuff? And there's a lot to it. There's this kind of funny stereotype in medicine about orthopedic surgeons kind of being blunt instruments. You break bone, we fix bone. But there really is a lot to it. It's a lot harder than it looks, I would say. One thing he spent a good amount of time talking about was scaphoid fractures. These are really easy to miss. So this often presents as pain at the base of the thumb after somebody falls on their hand or whatever, gets some kind of trauma to the area. He was saying if you're getting an x-ray of a hand and wrist to look for a scaphoid fracture, you want to request a scaphoid view or request emphasis on the scaphoid. I don't know how to say that correctly. But the way they do that is actually deviate the hand to the ulnar side while they're doing the x-ray so that you can see the scaphoid better. As far as physical exam, you can have the patient kind of hold their fingers spread out so that essentially you're putting the thumb in extension, and then you press inside the anatomic snuff box right at the base of the thumb. And if there's pain there on palpation, that suggests you could have a scaphoid fracture that you need to look for. Because of the way the blood supply to the scaphoid is, it's really prone to avascular necrosis in certain types of fractures. So he's really big on getting an MRI quickly if you suspect a scaphoid fracture. He talked about blood supply too of the femoral neck. He was saying that the tension side femoral neck fractures are more concerning or more likely to need surgery than the compression side fractures. So if you're just looking at a femur in normal anatomic position, the tension side is the superior side of the femoral neck, and the compression side is the underside or the inferior side. And again, that's an issue with blood supply and more likely to have avascular necrosis just because of the way the anatomy of the blood vessels are. So top side femoral neck fracture is more important than bottom side femoral neck fractures. He went through that Ottawa ankle rules that help you decide when to order imaging for an ankle injury. So you can check that out if you want some guidance there. There's this tool called the West Point ankle grading system that can help give you an idea of how long to tell a patient that it might take for this to heal. He mentioned using acupuncture specifically for pain coming from a rotator cuff problem. He said he's a really big fan of doing that. He was a very cool presenter too. He is a sports medicine guy. I think he was involved with the University of Miami sports teams. He himself had a big, cool looking mohawk. I'm like, oh yeah, I bet he's fun to hang out with in the locker room when he's taking care of these players and whatnot. So that was a pretty neat presentation. The next presentation was on falls, delirium, and polypharmacy and geriatrics. I was very proud of myself because I really wanted to skip this session and go get a donut from this interesting donut shop across from my Airbnb, but I didn't. I sat through the presentation because I'm like, this is very pertinent to my practice. This is important. This is what I'm here for. Pat me on the back. I'm a big boy. I stayed and listened to the presentation I came to hear. The polypharmacy discussion was pretty much what I expected. It's the same stuff that I talked about in the deprescribing episode, which was a couple episodes ago. You know, it's great not to use these medicines in old people if you can. Alternatives, we don't. Gosh, it still just feels like an impossible situation. I was hoping to pick something up that would help with that situation, but I really didn't. She mentioned a tool called the Tinetti Balance Assessment Tool. That's TINETTI. That gives you a bunch of specific tests and a grading scale that you can use to figure out how affected a person's gait and balance are. She talked a lot about how vision issues increase the risk for falls, which makes sense. I don't know that that's something I consciously think about, but, duh, it makes sense. Cataracts are something that increase a person's fall risk quite a bit. She also talked about how having split lenses, like people who have bifocals, trifocals, that's actually a big fall risk if they're looking through the wrong part of their glasses when they're trying to walk, which, again, pretty obvious. I don't know that I would have really thought about that, but that makes a lot of sense. She feels like it is safer to actually have a different pair of reading glasses and then a pair for long distance vision rather than just having the split lenses as far as decreasing a person's fall risk. And we should make sure we remind our patients not to try to walk around when they're wearing their reading glasses. When she was talking about delirium, she mentioned a tool called the Confusion Assessment Method, or CAM, which is a validated tool to help identify delirium in patients. The next presentation was updates in cardiology guidelines. This was by a person who helped write the guidelines that will be coming out soon and has helped write a lot of the guidelines in the past. So it's always interesting to hear from a person like that who's in the room helping to make these big decisions. She pointed out that PCSK9 inhibitors are really only approved to be used in conjunction with statins. And I will admit that I probably have thought about that as a thing that people who can't or won't take statins should consider, oh, well, if you can't do the statin, you should do the PCSK9 inhibitor instead. But really, they are approved to be used together. She talked about kind of the newer definitions of heart failure. We don't just call it congestive heart failure anymore. It's been, for a while, heart failure with preserved or reduced ejection fraction. And now they're throwing in some new terms, which are heart failure with improved ejection fraction. So that means that you were in HFrEF, but now you're better. And then there's heart failure with mildly reduced ejection fraction. That would be an EF of 41 to 49%. So reduced ejection fraction is anything less than 40%. Preserved ejection fraction is 50% or greater. So if you fall in between 41 and 49%, that makes you heart failure with mildly reduced ejection fraction. Another way to think about HFpEF, heart failure with preserved ejection fraction, is diastolic heart failure. Maybe that's something that I had a little bit confused in my head, but it makes sense. The heart can't relax enough to fill properly, but it is still maintaining an appropriate ejection fraction. So diastolic heart failure, aka heart failure with preserved ejection fraction. She reiterated guideline-directed medical therapy for heart failure. Of course, we have our 4 pillars of guideline-directed medical therapy. That's ACE, ARB, ARNI, one of the 3. Beta blocker, mineralocorticoid receptor antagonist like spironolactone, and an SGLT2 inhibitor. Anybody who has heart failure should be on all 4 of those things, and they should be on them forever, even if their heart failure improves. So even if they're a heart failure with improved ejection fraction or a heart failure with preserved ejection fraction person, even if they get a lot better over time, they should stay on these 4 pillars indefinitely if they ever had heart failure. She mentioned that diuretics are used to make people feel better, right? They help with the congestive symptoms. They help people breathe better, but they do not make a difference in heart failure outcomes. So a lot of times we think about using Lasix or some of the other diuretics to help with heart failure, but remember that that's just helping the symptom. It's not really doing anything to help the underlying disease. And we should always just be using the minimum amount of diuretic we can to help make the patient more comfortable. I don't know if I'd thought about this before, but she pointed out that if you give somebody a diuretic, make them lose too much fluid, then all the mechanisms that we're trying to block with this guideline-directed medical therapy are kicking in to try to compensate for the fluid loss, which makes a lot of sense. So go easy with the diuresis. She was saying that in her experience, putting people on SGLT2 inhibitor actually makes people feel better pretty quickly. She was saying, a lot of these medicines do not make the patient feel better. They actually make them feel worse. But it's nice to use the SGLT2 and actually see the patient feel better pretty soon. She reinforced that sodium restriction and fluid restriction don't really make any difference in heart failure outcomes, so there's no reason for us to be telling people that they have to avoid eating any sodium or restricting their fluid intake. She said really the only reason to do fluid restriction for somebody is hyponatremia in the setting of SIADH. If you have a patient in heart failure who is stable, there's no reason to get annual echocardiograms. You only really need that if there's change in status or to continue to have symptoms or whatever. She talked about AFib. Of course, we're kind of leaning more toward early rhythm control with ablation therapy at this point, but there's still a huge, in-depth discussion process and thought process that goes along with that. So that's not a simple decision. That's definitely a cardiology decision. She talked about when anticoagulation is indicated for atrial fib. Of course, that's just based on the CHADS-2 VASC score. If that score is greater than 2 for men or greater than 3 in women, then anticoagulation is indicated. She pointed out that anticoagulation is still indicated for a person who has a high CHADS-2 VASC score, even after they've undergone a successful ablation. So even after they're out of AFib, if their stroke risk is still high, then really the anticoagulation should be continued. That's got to be kind of a bummer for the patient. I would think if you're going to fix my rhythm and I'm going to be back in sinus rhythm, why do I have to be back on blood thinner? But really the true treatment is to still leave them on anticoagulation if their stroke risk is high, period. Of course, DOACs are preferred these days. You still have to be on warfarin if you have moderate to severe mitral stenosis or a mechanical heart valve, but other than that, we would prefer people to be on DOACs. When you talk about rate control with AFib, the goal for resting heart rate now has come up to 100 to 110. It used to be much lower, but they've found that it doesn't really make a lot of difference. So you can allow the rate of AFib to be a little higher. Digoxin, definitely not preferred. Really, you only want to use digoxin if you can't use a beta blocker or a calcium channel blocker for rate control. If the ejection fraction is less than 40%, you do not use calcium channel blockers. So a person who has HFrEF then should not be on a calcium channel blocker for rate control for AFib, or I guess any other indication. She was saying that you would think caffeine would be a trigger for atrial fib, but it's not. She pointed out that spironolactone has a testosterone blocking effect. It can lead to things like gynecomastia and problems with sexual function. So she was saying that eplerenone is a lot better for treating younger men with heart failure. She was talking about how the thing with putting Black people on calcium channel blockers and thiazides preferentially is still a thing. And she floated this theory that she said was just her own personal theory, although the other speaker they were kind of having a conversation, and the other speaker was like, oh yeah, I've read that before. There's some evidence of that. So I haven't looked into this myself. I don't know how valid this is, but she was saying that back during slavery times when you had these long middle passages, right, where slaves were on their way from wherever they came from to here in a boat. A lot of them died on the way. And she was saying that probably the people who were more likely to survive that middle passage were the ones who were just naturally better at holding on to salt and water and not becoming dehydrated. And so she thinks that that historical fact has led to more holding on to salt and water in Black people currently. So that's why thiazides in particular seem to work better in Black patients. Very interesting theory. I know when I've talked about this on the podcast before, I've said, oh, all this race-based stuff tends to be wrong, and I kind of halfway ignore it a lot of the time. And she said that too. She was saying, we're moving away from race-based everything. But then she talked about this and she said, yeah, I think this does still make sense. The last section was a rapid fire update on a bunch of medical literature, just kind of reviewing articles that have come out in the past year or two. I'm not going to try to give the name of the individual articles or whatever. I took notes, and this is my little outline. These are the things that I picked up. So each topic comes from a new study. So here we go. Rapid fire updates. Air pollution may increase the risk of venous thromboembolism as well as prediabetes and diabetes. New topic. The FDA has changed their definition of what counts as a healthy food based on the food's content of sodium, added sugar, and saturated fat. The last time they updated this definition was back in 1994. And they're coming out with this red, yellow, green color code system that should be on labels of food by 2027, I believe she said. New topic. When you're thinking about primary prevention of stroke, you should consider social determinants of health along with other metabolic risk factors. There's a tool from the American Heart Association called the Life Essential 8 tool to help you think about stroke risk. And it's kind of like all the stuff we already know. There's nothing groundbreaking in there. GLP-1 agonists are recommended for people with high stroke risk. For the first time, they're now considering pregnancy-related factors in a person's stroke risk. And for the first time, they are considering the effect of long-term hormone therapy in transgender folks. She was saying that's kind of a new thing. This is an experiment that's going on in real time. So that's a new thing that they're thinking about more. New topic. Vitamin D for disease prevention. They've kind of decided that having vitamin D deficiency is not really a problem. If you're an adult age 19 to 74 who is not sick, doesn't have any other problems that are definitely associated with vitamin D, so that would be like CKD or osteomalacia. If you're just a generally healthy adult person and you happen to have vitamin D deficiency, it probably doesn't matter. They do still suggest getting the recommended daily allowance of vitamin D intake, and they still recommend vitamin D supplementation for people over 75, although apparently there's really no evidence that does anything, as well as pregnancy and who are at high risk of developing diabetes. So vitamin D, probably no reason to be checking that in healthy people unless you have some very vitamin D related problem. New topic. Pneumococcal vaccine now recommended at age 50, and the current preferred version is the PCV21. She went through and talked a little bit about what the difference in PCV and PPSV vaccines is, and it just came down to the PCV vaccines cause a better immune response than the others. So that's why they're kind of moving toward being the preferred alternative. And she was saying that there are some new ones of these coming out. So these guidelines on the pneumonia vaccine have changed rapidly in the past few years. It's been kind of hard to keep up with and a little frustrating. But currently, PCV21 recommended for everybody at age 50. New topic. Eating later in the evening seems to be correlated with worse glucose tolerance over time. The studies that looked at this actually considered late to be after 5 p.m. So if you're not out with the early birds eating dinner, you're more likely to have worse glucose tolerance. And of course, the point of that just is it's better if you can not eat later. I think we're all kind of absorbing that message anyway. New topic. She talked about herbal and dietary supplements and hepatotoxicity. I didn't really get any specific information from that. Really what I got was just remember that people can be taking a lot of herbal or dietary supplements that could be bad for them. There was a whole section on that in the Neph Madness material for this past year that was a bit more in depth, I guess. But really, that came down to sort of the same thing too. Like, hey, some of this stuff could be bad for your liver, so just watch that. And she mentioned some of the same tools that they mentioned in Neph Madness as far as places that you can check on these drugs and interactions with the supplements and that sort of thing if you have specific concerns. New topic. Be careful with gabapentin. We're finding a higher risk of COPD exacerbation associated with gabapentin, and also it can cause edema, and also, of course, it can cause drowsiness and dizziness and increase the patient's fall risk, so be careful with gabapentin. New topic. chronic insomnia with chronic pain. Again, the CBTI came up, chronic behavioral therapy for insomnia. There are therapists who specialize in that. Evidently, it's a little bit difficult to find those therapists, but there's all kinds of literature. And of course, the app that we mentioned earlier is all out there. So people dealing with chronic insomnia, especially those that have chronic pain, might benefit a lot from the cognitive behavioral therapy, however they're able to get it. New topic. There's a trial that looked at duration of antibiotics for people who have uncomplicated bloodstream infections. A bloodstream infection sounds pretty complicated in itself to me, but they actually looked at people who were hospitalized and even people who were in the ICU. And I guess uncomplicated bloodstream infection means they're not septic, they're not in septic shock, but they have a disseminated infection. I'm not sure. But anyway, the study showed that usually 7 days of antibiotics is just as good as 14 days of antibiotics as far as long-term outcomes. New topic. The Prevent CVD risk calculator is better than the ASCVD risk calculator, and that's what's going to be in the guidelines moving forward. I think we are already aware of that. New topic. Vitamin K2 daily might help people with idiopathic nocturnal leg cramps. That's a very common complaint that I often don't feel like I have a lot to offer other than like you could try some magnesium, you could take a sip of pickle juice, make sure you're well hydrated, blah, blah, blah. Let's make sure your circulation's okay, make sure you don't have neuropathy, etc. But for idiopathic leg cramps, vitamin K2, taking vitamin K2 daily might be helpful. Obviously, you don't want to give that to people taking warfarin. New topic. There's a new blood test for colorectal cancer screening, which actually was not mentioned in the colorectal cancer screening talk. We've had a rep for this show up at our office. I don't know that we have used it yet, but if you have somebody who can't or won't do a colonoscopy, can't do the Cologuard, won't do the FIT testing, then this blood test might be a good alternative for them. The data on it are not great, but it's probably better than nothing. The Cologuard test definitely is better if you can get people to do that. New topic. They've come up with an actual new definition for long COVID. Pretty excited to see something like this coming out. This is actually from the National Academies of Science, Engineering, and Medicine. And so if you look that up, looks like you can get for free what the actual definition of long COVID is. And it's pretty in-depth as far as the different symptoms and diagnosable conditions and features. There's a New England Journal article about it that has a pretty good little diagram or pictorial thing here. This is all available for free. So check that out if you're interested. If you Google NASEM long COVID definition 2024, you can find these things. New topic. Walking helps prevent recurrence of low back pain. New topic. Orthostatic hypotension can occur over a longer period of time in people over 70. So, you think about if a patient's orthostatic, that means if they, you check their blood pressure after they stand up, it's going to drop a little while after they stand up, but this can happen over like many, many, many minutes after they stand up in an older person, like way longer than you would wait to check in the office. So just keep that in mind when you're dealing with older folks talking about syncope and fall risk and that sort of thing. New topic. She very briefly mentioned DoxyPep. This is post-exposure prophylaxis for STIs where you take some doxycycline after a sexual encounter to hopefully prevent things like gonorrhea, chlamydia. And the results on that so far are pretty mixed. And also we don't know the effect on antibiotic resistance over time. So DoxyPep, mixed results so far. So that's it. That's a very rapid fire, very concise summary of the things that I picked up on over this 2-day conference. Highly recommend Pri-Med events. If you are looking for a conference to go to, I think I got a little over 12 CEUs for showing up to this conference for a couple of days and got to get out of town for a minute. And it was a little better than going to work every day. So if you're looking for a reputable conference to attend, I highly recommend Pri-Med. I think I'll probably be going to some more of these moving forward. I hope some of this was useful for you. Let me know if you have any questions. As always, special thanks to our Patreon supporters. Thanks to everyone else for listening. I hope you learned something, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.